all the dignitaries on the dais, but also in the audience. I think all of you, what you have done, what we're seeing here today is an incredible example of women coming together to address uh, public health priority, a growing need, and the best of my knowledge, it's perhaps the only speciality as a women, all women group, and that meets regularly and that's growing from strength to strength. So let's all give a good hand for ourselves, for all of you, and of course for all the pioneers who are sitting here on the dais. I don't want to name each one of them because you have heard of them, they have been recognized, and it is really in their footsteps, I think, that we see a lot of the younger nephrologists they are following, and I'm told that there are many more women now taking nephrology than there used to be in the past. Certainly, when I was doing my MD, it was a very male-dominated field. In fact, I did pediatrics, and pediatrics was always one specialty where you had a lot of women, or maybe women outnumbering men. But in many of the other specialties of medicine and surgery, particularly, you saw very, very few women. But there were role models even at the time when I was doing my undergraduate and postgraduate. We had Dr. Padmavati and her sister Dr. Janaki, of course, both of them who devoted their life to medicine, one a neurologist, the other a cardiologist, lived to a ripe old age. We had the great pleasure of meeting both of them. We had Dr. Shaka Menon right here in Chennai, who started SCARF, and of course Dr. Shanta, who started and they all dedicated their lives to the field and to the organization. So the Adyar Cancer Institute. We had a radiologist who was banking on her name just now, who was the director of AIMS, the first, and I believe the only woman director of AIMS. And then Dr. Vidula Rohatgi was the head of the pediatric surgery department. She died very tragically in a train accident. The Rajdhani train accident was also in that train. And we were all going from Delhi to Calcutta for the Indian Academy of Pediatrics conference, possibly somewhere in the early 90s. And there were several people who died in that. It was a derailment. And Dr. Vidula Rohatgi was one of them. It was very shocking because she was the first woman head of pediatric surgery at AIMS. So in those days, there were few and far between women leaders in medicine. In fact, if you look at the Nobel Prize in medicine, there are very few women, I think hardly 10 or 12 who have received it. And that too, the first one got the Nobel Prize in medicine in 1947, which was Dr. Corey, who described the Corey cycle. Glycolysis cycle in cells. And the latest one, of course, in 2023 was Dr. Kathleen Perico, who received the Nobel Prize for her work on mRNA. mRNA became famous during COVID because of the vaccines, but her work on mRNA started in the late 80s. And she worked in universities. She's Hungarian by birth, but she emigrated to the US so that she could carry out her research. But she was discriminated in the sense that she was not really encouraged. Nobody thought that there was any future in mRNA. And she also, in her autobiography, has described all the challenges that she went through, and many of them were related to being a woman, because she also had a male colleague working on mRNA, and while his position was secure at the university, I think it was Philadelphia at that time, but she was constantly being asked to move because she could not bring grants, and her salary was not being supported by the university. But despite all that, for 30 years she persisted in working on mRNA, and that eventually led to a vaccine during a pandemic which nobody expected. A vaccine in a record period of time, within a matter of under 12 months. We had not one but multiple vaccines. Of course, the 2 mRNA vaccines were used very widely across most of the high-income countries. And in the rest of the world, including India, we had other vaccines like the adenovirus vector vaccines and the killed inactivated vaccine and the other protein subunit vaccines. But so the lessons from Catalin Carrico's work really show that sometimes it can be very, very hard for life and you have to be very committed to that particular area and believe in it. It has to be your passion for you to continue, but you never know when the reward will come. And I'm sure she did not, in all these years that she worked on it, did not expect that her work would, in one day during a pandemic, save millions of lives, or that she would receive a Nobel Prize. She did it because she believed that there was uh, scientifically that it was possible to use mRNA to deliver not just vaccines, but any antigen that you want to deliver. And today, mRNA platform is being used to develop many, many drugs, vaccines for other diseases, as well as monoclonal antibodies that we can use. So sometimes a career in research need not be rewarding always, but you always get small rewards and small satisfaction when you do research. So I was very happy to hear about the registry that you are running. I think registries can give a lot of information. They're very, very important. I know when I was DG ICMR that we were supporting several registries for stroke, for myocardial infarction, for psychiatric conditions. Because what happens in busy hospitals, particularly in government, but also in private hospitals, is that enough attention is not paid to the maintenance of records. And the big difference, I think, between countries like us and say the very highly developed countries, particularly if you look at the Scandinavian countries, the medical records are so complete, the birth and death registries are so complete that you have all of the data that you need to do analytics. And from year to year, you can look at the changes that are happening in the disease burden, in the causes of death, in what's happening to people's health. You can keep a close tab on it, and therefore the policy also can be modified and altered as per the current needs. Now, when I was in ICMR, we discovered that we did not have a disease burden estimation of disease burden in the country state by state. So in 2017, we released in collaboration with Global Burden of Disease at the University of Washington in Seattle. As you know, the IHME has been doing the GBD work now for over 20 years. Very, very valuable work. A lot of it is based on modeling where there's no data. So we partnered with them and the Public Health Foundation of India and released, Vice President of India at that time released a report which showed state by state the disease burden. For the first time, it became very obvious that the southern states in India had already undergone an epidemiological transition way back in the early 90s, and that the leading causes of death were non-communicable diseases. Because when you take India as a whole, you take an average, it really does not represent the population. Because such a huge population, 1.4 billion people, we are almost like the whole of Europe, and every state in India is bigger than many countries in Europe. So having one statistic, and particularly we know that developed country also our states are very varied, the health services, the other parameters, socio-economic development, literacy, everything is different. So this state level disease burden showed that in the northern states also you had Punjab, Himachal, Gujarat, some of the more developed states, they had a more NCD prevalence, 60-65%. Whereas if you looked at Bihar, UP, Madhya Pradesh, Odisha, still there the burden was because of infectious diseases and maternal and child health conditions. So since then, this disease burden has been updated periodically. The ICMR keeps on updating. But the point is really that without understanding the disease burden, the prevalence, the trend of any particular risk factor or disease, we have to know both the diseases, which are the endpoints, but also the risk factors. How are the risk factors changing? And today, if you look at risk factors in India, they're very different from what they were 25, 30 years ago. At that time, we said undernutrition, poor sanitation, poor and unsafe drinking water. These were the top risk factors. And so our disease burden also reflected that. Today, if you look at those have all come down. They're not disappeared entirely. Still, in many parts, safe drinking water, sanitation, and malnutrition persist. But what we have seen is an increase, tremendous increase in other risk factors, which are both environmental but also behavioral. So, in environmental risk factors, we see that air pollution is today the number one risk factor for health. This includes indoor and outdoor air pollution. If you add up both, it becomes number one. And people don't recognize what a big impact it's having on our health. Because it's kind of invisible and we get used to it and it's there all the time. And we're very satisfied when it comes down a little bit. There's a rain and then the AQI comes down. So we're all happy that it's temporary. If you look at WHO cutoff for PM 2.5, which is 5 micrograms per cubic millimeter or 15 micrograms per cubic millimeter average per annum. The Indian cutoff is at 40. The national air quality standards already set our cutoff a little bit higher. And yet, most cities in India do not meet those standards for most parts of the year. The average AQI in India is around 55. And if you look at North India today, which is post-monsoon, has the best air quality. The average is around anywhere between 60 and 80. And if you look at the annual average, it will be closer to 100. Even cities like Mumbai and Chennai, which are on the coast, where we get a lot of sea breeze, the AQI has been progressively worsening over the last few years. Now, it's not just linked to respiratory disease, as most people think. It's linked to asthma and lung disease. Yes, it is. It's also very much responsible, I believe, for the increase in diabetes, in cardiovascular disease, in general inflammatory and metabolic diseases, in brain diseases, degenerative diseases, and it also unfortunately has a very bad impact on child growth, brain growth, so the cognitive development of children. And of course, all of these risk factors are always worse in the poorer socioeconomic groups because they don't have the means to improve their own air quality. Like some of us can put air purifiers in our homes. Not everybody can do that. Indoor air pollution is a very big problem, and I say this because this is a room full of women and very knowledgeable women. But the fact is, and many people don't know, that household air pollution, because of biomass burning, still contributes over 40% to the overall air pollution in India, particularly in the central, above the central and northern India. If you look at the sub-Himalayan plain, Indo-Gangetic plain, it stretches all the way from Rajasthan to the west to Odisha, Bengal in the east, and also Nepal and Bangladesh. We see that air quality there, a lot of it is contributed through biomass burning. And the simple solution for that is to provide clean cooking fuel to women. So this is an issue actually which, and of course every household in India today has an LPG connection because of the Ujjwala, Prime Minister's Ujjwala scheme. Was a huge step forward for health, for gender equity, and to address outdoor air pollution. So it's also our energy access, right? So a lot of women in Asia and Africa still depend on biomass for cooking or heating. And so energy access for the poorest communities is an issue that one will have to deal with in the face of climate change. So we have to look for solutions which can have both a positive effect on the environment and on health. There are many areas like this where you could look at trade-offs and you could look at synergies. I believe that this is one of them, improving access to clean cooking fuel for women, which will result in health impacts, I think, which can be seen very quickly, including on all of the metabolic diseases that all of us are seeing. I'm sure all of you see in your day-to-day practice the impact of increased diabetes and hypertension on kidney disease, and that's when the patient comes to you. So we were just talking a little bit earlier about prevention versus management. And as doctors, we are trained to treat people who come to us sick. I think very little of our medical education is focused on prevention or health promotion. At least I didn't pay much attention. I wasn't. Maybe it's changed now. But I believe that our medical curriculums don't have enough. Our practical experience doesn't have. When we do our internship, how much do we know about, we talk about prevention, how much do we actually learn? And our health outlays, if you look at the outlay, the budget for health, how much of it goes to prevention? It is maybe 10 or 15% that's going to preventive health care. Primary health care, when it was conceived by the board committee, was very comprehensive. And even today it continues to be. The overall, when we talk about comprehensive primary health care, it is prevention, it is promotion of health, of course, then it's management of diseases, it is also includes rehabilitation and palliation. So that's what comprehensive primary health care is supposed to provide. All of the needs to keep you healthy, to keep the community healthy, to keep individuals healthy. So that's what public health really is about. And as doctors, I think we have to invest more of our time, energy, advocacy, communications on disease prevention, because otherwise, I think the end result of not paying attention to that is more e-health and more burden on the health system. Can you imagine the number of the dialysis centers we have today are not sufficient for the number of patients who need it. It's also painful, very costly. We were talking about the amount of water that is needed for dialysis, the amount of plastics that are generated. So it's a huge issue also when you look at sustainability and environmental health. We're actually generating a lot of that. Similarly, when you come to heart attacks, you come to stroke, you come to any of the complications, it is hugely expensive for the family, for the individual, and for the government. And at the same time, it impacts your quality of life. Our life expectancy today is 72. Okay, it's gone from 34 at independence to 72 today. It's something we can be very proud of. But how much is our healthy life expectancy? There we are not doing so well. Our healthy life expectancy is about 60. It's about 10 years less, 10 to 12 years less than our life. What does that mean? It means that the majority of us spend the last 10 years of our life in very poor health with multiple comorbidities. And so I think when we talk about life expectancy, we should really investigate healthy life expectancy and how we can make that better. There are many, many papers written about how you spend the most amount on health in the last 6 months of your life because of all the complications that one has. Now, as Indians are going to live longer, and we want people to have a longer life expectancy for sure, but we want them to have a healthy life expectancy, not just live, but also have a good quality of life. We are going to see increasing numbers of people with degenerative diseases or all these metabolic. It's normal that with aging you get more cancer, you get more of these types of diseases, especially the neurodegenerative diseases. So we also have to prepare ourselves for, and there's a lot of debate, if you see in the newspapers today, you'll see a lot of debate on our population and whether we should be stabilizing or not. Right now, we have a demographic dividend. We have a very young population compared to most parts of the developed world. So we have a huge advantage, but that advantage will last for the next 20 to 30 years. And after that, we will also then split into a graph where the elderly percentage would keep increasing. I think today over 60 something like 12%, going to be 20% by 2035 or so, and by 2050 it's going to be well above that. So we need to prepare for that along with urbanization and all the other changes which are happening in the society. So I think the whole idea of research is extremely important, and this group can do a lot because you're still a manageable size and you're very committed on what I can see. You've already initiated this registry. I think it's fine tuning that. I have come across a few other groups like this in India, which are small, like there's a group that does ICU, critical care research in ICU. And essentially what you need to do is have that discipline of making, recording the information in a very systematic way. And this is how in the US I've seen amazing research coming out of people just collaborating. You know, what you need is a group of people to maybe sit down, think together, what is it that we want to capture, what are the key elements, and you learn as you do. You might have listed few things. Of course, if you can add lab investigation, genetic profiling results, etc., that adds values, CT scans, and today, with the kind of digital technology we have, it's very, very easy to capture and upload all these. Once you organize yourselves into a format, you can capture it. And then one can actually open up this type of data set to the younger group, people who are doing their MDs or DMs who want to do thesis, or even anyone else who's interested in research. Write a protocol, access the data set, analyze it, and publish a paper. Today, research is a lot of it is interdisciplinary. So one would need to include people with statistical expertise in your study. There are also large data sets today which are available, which sit in different departments, sometimes without being fully used. The National Family Health Survey is a very good example of a data set which has been made available to researchers for secondary research. You can access the data set and use it. We used it last year to look at the impact of climate change on the health of women and children in India. This is again a topic which we will all have to deal with in the years to come. With increasing heat, we can expect kidney diseases to go up even more because we know one of the risk factors is chronic exposure to heat, perhaps without drinking enough water or staying hydrated. And there are many women in occupations which are highly at risk. And personally, I have spoken to salt pan workers, I've spoken to fishermen, I've spoken to women in factories, in many such occupations where they don't have good facilities for toilet, to take a break, to have access to drinking water, particularly cool drinking water in the summer months. Forget about air conditioning and all that, but not even shade under which they can rest. So there are a lot of, health is very much linked, I think, to many of these societal issues. We know that there are social and economic determinants of health which are outside our health system. They're way outside what hospitals think about or do. And so these social and economic determinants of health, they keep on changing also. And so we need to keep investigating that. So registries will tell us, if you start seeing some signal, say a particular group of people seem to have a higher risk of X, then you can start asking the questions why. Do salt pan workers have a higher prevalence of kidney disease? If so, what could be the risk factors that they are exposed to, and so on. So I think that a women's group like this must also look at, advocate for, and understand women's issues in the context not just of just the biomedical aspects of it in a hospital, but really go beyond that to the social determinants. And I was telling you about the study, so very quickly we looked at NFHS data, which gives you the population level indicators by district, and we overlaid it on climate data from the meteorological department. And what we found was that in districts of India that were exposed to drought over the last 10 years, compared to districts that were not exposed to drought, there was a higher prevalence of women undernourished, of anemia, of women who got married underage, under the age of 18, of teenage pregnancy, particularly in children. We found higher malnutrition, lower dietary diversity, and more dropouts from school. So, impact of climatic hazards like repeated droughts, cyclones, floods, etc., on the health of women in particular. And we just completed another study that looked only at heat impacts. And we found that there's a significant association with increased hysterectomy in those districts which had high heat vulnerability index. So it's having impacts on women in many different ways that we have not thought about. I did not expect to see this correlation with hysterectomy and high heat, you know, in certain selected districts. But if you really think about it, you can try to understand why women might want to go for hysterectomy if they have to do physical labor in the hot sun. So this is also leading to migration, and many different things are happening now because of climate change. And this is going to have a very big impact on health. We haven't fully understood and unpacked it yet. So more research is going to be needed in this field, but also more solutions. It's not just, we shouldn't be satisfied by describing the problem. Very often as doctors, we describe the problem, but we need to go a step further to address it, to think of solutions, and this is where we have to partner. We cannot do it alone. We have to build partnerships, collaborations. There are a lot of innovators in India today, a lot of startups coming with lots of solutions. We can partner with them, we can test some of those, whether it's for prevention or whether it's for management or whether it's to reduce the risk factor. So finally, I would say that as doctors and as medical scientists, we also need to communicate much more. We are very busy, of course, all of you are very busy doing clinical work. We are satisfied and we get a lot of satisfaction from making people better, obviously the patients. That's our first responsibility. But I think we have a larger and broader responsibility to society, which is to communicate health. If you see today, there's so much misinformation in social media. All sorts of people start influencing opinion. Sometimes they're celebrities, sometimes they could be other people. We don't know why they communicate certain things. But many of the things I see on social media today are factually incorrect and are very dangerous. And a lot of young people might get influenced and believe it, especially when it comes from prominent people. We see the kind of vaccine misinformation now that's unfortunately coming out of the United States, where they're reversing decades of progress now by sowing the seeds of doubt in people. Once you sow the seeds of doubt in people, it's very difficult to change that perception. I still get asked by many people, tell us the truth about COVID vaccines. Must be something wrong somewhere. There's some secret. And I say it's the biggest, I would say, proof that science actually delivered. That all the years of investment, like I told you, 30 years of mRNA research delivered during the pandemic. There is no conspiracy there. There is no, yes, every vaccine has a side effect. There's no doubt about that. But 1 in a million versus the number of millions of lives that got saved. You've got to see the benefit-risk ratios of these things. So communicating health data in a very twisted manner, or picking out just one thing and saying, I know one person who died of a side effect. Yes, but out of how many millions of people who got saved, Certainly for that person, it's a terrible disaster. So we have to learn to communicate these things in a factual manner. Science keeps changing and evolving. So we also need to be up to date. And during COVID, I think we all learned that, right? People used to say, but yesterday you said this and now you're saying this, that means you don't know what you're talking about. Say, well, the knowledge has improved. Because during COVID, every day there were 20 papers being written, So one has to keep up. So as scientists, as research people, or as people of medicine, we have to be evidence-based and data-based. So I think it's really important. I want to again end by congratulating this group, and I'm very happy that Anthony came and met me and invited, And I said, okay, this is a very unusual group and I should go and participate and meet and try to share some thoughts, but really encourage you to focus some of your time and energy on research, but also on health communication, on especially prevention and promotion, because doctors' voices count. There was a survey done globally, which right after the COVID pandemic, which showed that the trust, they were looking to see who do people trust. The trust in physicians and scientists was still high. The trust in journalists and politicians, unfortunately, was low. So I think we have to capitalize on the fact that people trust doctors. And it's our responsibility to use that trust to improve the health of public and community at large, in addition to doing it for individual patients. Thank you very much for giving me this opportunity.
Thank you very much, ma'am, for reiterating the importance of research and registries.